Welcome to the Emory University Department of Emergency Medicine Image of the Week podcast. I'm Sierra Beck, and I'm really excited to bring you this week's images. Kudos go to Jean Wheeler and MS4 Erica Colvin, who took these awesome pictures at the bedside. So their patient was a 43-year-old male who presented to the ER for several weeks of progressive left lower quadrant abdominal pain. He had seen a doc a week before, and at that time was given a diagnosis of diverticulitis and started on moxifloxacin. Despite antibiotics, his pain continued to worsen, and so he returned to the emergency department. So can we really do an ultrasound for diverticulitis? Well, bowel ultrasound is an emerging point-of-care modality, and the real advantage of ultrasound is the dynamic nature of the test. We can ask patients to identify the location of their pain and then use this information to guide our exam. This technique is widely applied when evaluating patients with acute appendicitis, and the same technique can be used to identify alternate bowel pathology. This patient identified pain in the left lower quadrant, and when the probe was placed in the abdomen in this location, this is what they saw. So normally when we ultrasound the abdomen, we see a lot of dirty shadows from air-filled loops of small bowel. It may be necessary to apply gentle compression to move the bowel away from the underlying colon. Normal colon can be differentiated from small bowel on ultrasound by its lack of peristalsis, its fixed location, and its lack of plicae circularis, those small folds that are within the small bowel wall. In the far field of this image, we can see a segment of colon, and here it has thickened walls. We can also see some hyperechoic fat surrounding the colon, which is suggestive of surrounding inflammation. And then in the near field of the image, occupying most of what we see, is a large area of mixed echogenicity with a hyperechoic rim that is suggestive of an overlying abscess. If we play the video, you can see what the provider saw in real time at the bedside. Here we can see that loop of colon in the background, and then this hyperechoic fat that's surrounding it. And then we see this large abscess cavity occupying most of the image. It has these small hyperechoic areas with shadowing that suggest air within the abscess cavity. A CT scan was subsequently obtained that confirmed the ultrasound findings. In this image, we can see a thickened loop of bowel again and an overlying abscess. If we follow the video, we can trace the colon as it changes from sigmoid colon into descending colon here. Again, we see an abscess cavity with an air fluid level and then some fat stranding around that area. So to review those findings again and compare the ultrasound to the CT scan, we see a thickened loop of colon with a wall measuring greater than 5 millimeters across. We can see enhancement of the surrounding fat, and then we see a large abscess within the picture, which corresponds to the findings that we saw on the CAT scan. So this is a great recent article in the Journal of Ultrasound in Medicine that reviewed the ultrasound findings in diverticulitis. So the diagnosis can be made by identifying the following findings: a colonic wall that measures greater than 5 millimeters across, enhancement of the surrounding fat, evidence of abscess. You may be able to visualize diverticuli or air artifacts that suggest diverticuli, but these may be best visualized with a high-frequency linear probe. And then we can also assess for point tenderness on exam with compression of the probe, which may suggest the pathology that lies underneath. It's important to recognize that this exam is not without limitations. Views may be limited in obese patients. Although the scan was performed with the low-frequency curvilinear probe, it's actually best to obtain higher resolution images using a linear probe if possible. In reality, this may not be feasible in our larger patients. Also, bowel gas is our enemy, and if you can't compress the overlying gas, you won't be able to identify the colon beneath. Finally, some portions of the sigmoid colon are within the pelvis and are so deep that it may be difficult to assess them with transabdominal scanning, regardless of the patient's body habitus or the overlying bowel gas. Some papers have described using an intracavitary probe for this imaging, but this is probably outside of the scope of emergency medicine practice. Ultrasound may have a role in evaluating patients with diverticulitis, but remember this exam has not been studied in the hands of point-of-care ED providers and should not replace your CT scan. It may, however, be helpful to know the kinds of pathology you might encounter when scanning the abdomen. Ultrasound may be a useful tool in making an early bedside diagnosis or in cases where CT cannot be obtained. Remember to begin your scan at the point of maximal tenderness and know your limitations. Obesity, bowel gas, and inability to access certain regions of the colon may make your scanning challenging. Again, thanks for all your great images this week, and happy scanning.